Are you in focus or not yet?
Well, this slide is needs a new cover slip. So let's look at this one briefly, and then we can get in focus on the next slide. But that is in probably as best focus as I can get it. So this chapter is metastatic tumors and simulators, as well as the Appendix 2, which is exogenous agents and things. And then there's some other random stuff thrown in there too. So we'll just kind of lump them all together. We'll kind of go through them pretty quickly. And this one is more of a simulant. So this is the first one. This is endometriosis. And this one, you certainly can see it in the skin, and I don't know if it would actually be on the boards, but it certainly could be, and it's very much testable, particularly because it looks like it's some sort of tumor or something. And so it's more this pattern that you have to be able to recognize. And the pattern is that it's fibromyxoid stroma. It's just not very dense or cellular. There's these just large, kind of ectatic, what appear to be glands. And then there's usually lots of blood and erythrocytes kind of throughout the background stroma, and otherwise looks very much bland. And when you put all that together, that kind of speaks to endometriosis. Hopefully they give you some sort of history. This one, I guess it's not written on the slides, but this one says history fluctuates in size each month. Mm-hmm. So that probably would have been a little helpful. And when you get in further, you can see that it's sort of this stratified squamous epithelium. This is pretty thin here, but it can be decidualized. There's a picture of that in the book. That's pretty good, and that can look very pronounced and unique. But you kind of see this blood and debris filled areas. So this is endometriosis, and can look like it's some sort of neoplastic condition. Okay. So this one, I'll pause when we get closer in so everyone can get a little bit better focus. But this one from scan is not a simulant, but you can see why it can almost look like granuloma annulare or some other things with that almost like an interstitial mucin appearance. But this is cancer. This is metastatic breast. And the history thing that I have on here says woody plaque on chest. And, hopefully from scan you'd pick up that the unlike sort of this, seeing just sort of interstitial fibroblastic proliferation with mucin, but otherwise bland appearing, even from 2x you can see kind of jet black, hyperchromatic, larger atypical cells that are even larger than these little collections of lymphocytes. So you get lymphoid aggregates. That's usually not good either. And then as we get closer in, you can really make out these atypical cells. And this one, not as much, but they are kind of forming little kind of single file boxcar arrangement. And I'll go ahead and pause. You can kind of get a little bit better focus if need be. But you can see here some nuclear molding and just these large hyperchromatics nuclei, some increased cytoplasm as well. So just very atypical cells that are single file and just don't look good. So this is where you'd kind of throw lots of different stains and stuff on it. And then certainly that the history would be helpful. It's probably a plaque on the chest or breast or something like that. So this is metastatic breast.
Cook special. Dr. May special.
Did you biopsy that inflammatory?
Yeah.
Okay. Yeah, that was a classic picture, by the way. It was in Epic. So this one from scan, there's not a whole lot going on, but you do see a little bit of inflammation up here in this corner, and then what appears to be, something you might discount as just some squamous metaplasia or something, coming off the epidermis here. But then as you get closer in, you can see these cells are atypical. They do appear to be epithelial, which is why they kind of look squamous. But they're much larger and these very large nucleoli, and they're within lymphatic spaces. And then you got this sort of mixed inflammatory response around it. And the history here would hopefully be helpful as well, which for this one was rule out cellulitis of the chest wall. So basically, exactly what the patient that you had seen, and you can see, this is within true lymphatic space. You can see the little endothelial cells here around. Let me get that in view here. You can see the actual endothelial cells around, and just this little island of lymphatic extension of breast cancer within. Over here you can see it pretty well too, just within the lymphatic spaces. So we throw some stains on that too, and breast can be difficult because it can stain with different cytokeratin markers, and to where you still think it's nothing more than just a squame, but there are certainly some more specific things like the gross cystic disease fluid positive and CK7, some other things. This one I think came with the history too. Yeah, this one's interesting because the history was left thigh, nevus, rule out melanoma. And so if you're going through this quickly, which it's hard not to do for derm paths, so you're going through this quickly, you see like, oh yeah, there's something up here, and maybe if you're still kind of getting your derm path goggles on, you say, oh, that maybe is inflammation, but it's not. As you get closer in, these are all nevusites, so it's more of a congenital pattern. Maybe it's been a mole that's been there a long time, but I think the other cut, yeah, here you can kind of see that there are actually some little nests here, and it's maturing, so they're getting to single file, and they're more type C mature melanocytes, which is why they're so small, hyperchromatic, and looking almost like lymphocytes. But this is just a run-of-the-mill nevus. You can kind of see there again the nests and things. Intradermal nevus, maybe there's some compound, some stuff up there too. And it's probably been changing, but not because the nevus has been changing, but because below it there's metastatic cancer. And so this is more inflammatory breast cancer that was below it that it was kind of harder to see from scan. Hopefully your eyes would have picked up on these little spaces filled with epithelial kind of atypical cells, and this is a little bit more sclerotic. There's a lymphoid aggregate there that really shouldn't be there, and then with just that history. And so this one's kind of a twofer in a sense, and kind of scary. So a little bit closer on these cells, you can see they're just filling these spaces, and whether these are lymphatics or within the collagen, it's hard to say for some of these, but atypical mitoses and just these large weird cells. So metastatic cancer. Okay. Number 5, again, you can see that from 2x, this has kind of a busy dermis differential, but not quite like a scar or sclerotic edema or something like that. But those would be things you might be thinking of from 2x. This one was a scalp biopsy, I believe, and it says history: alopecia areata, no response to ILK. So, kind of a worst nightmare from a derm standpoint, but then you get the biopsy, and as you get closer in, you can see that these are definitely larger atypical cells. They're not just increased fibroblastic response or fibroblasts. And this is a good one where you can really make out the single file in many of these locations, or many areas in this biopsy. So kind of the Indian filing, or Native American filing. There is a little bit of maybe increased sclerotic collagen. And you can also use the boxcar term for some of these, and when you get the kind of the larger hyperchromatic ones that line up with that nuclear molding and all that, is kind of basically the same thing. So this one we throw a ton of stains on and then find out where it came from, which it's most commonly breast, but can be different things. So that's that one. this one is certainly a clear cell proliferation, and from studying throughout derm residency, pretty quickly on, you're like, oh, it's renal cell, metastatic renal cell, but it certainly could be other things as well. There's the balloon cell nevus, which can look very, very similar to it, and I want to say both are CD10 positive, actually. I mean, it can be confused with other things. There's clear cell melanoma. There's other entities too that we don't do as much in derm, but certainly in derm path that I learned about that are scary. So there's clear cell sarcoma, so the kind of the soft tissue deep version of melanoma. There's something called distinctive dermal clear cell mesenchymal neoplasm. There's other things where they can look very similar, and so but this does have a pretty good pattern for metastatic renal cell. It's commonly metastasized to the scalp, and you just get these, kind of theques of these clear cells, and can look very much almost like little nest pattern. Usually has this sort of arborizing stroma. It's RCC positive and CD10 positive, and sometimes it's deceptively bland. So as you get closer in, it really doesn't necessarily have marked pleomorphism or weird mitoses or stuff like that. So, but with the right history and just remembering that on the differential, it's usually not that hard because it's so obviously clear cell in origin. So that's that one. Okay, and then this is another one of inflammatory breast carcinoma. And you can see here, pretty small little punch, but these large kind of epithelial islands, atypical cells that appear to be floating and most likely are within lymphatic spaces, producing that that kind of inflammatory clinical appearance. And within these islands, you can see atypical mitoses. It is within, you see the endothelial lining, it is within lymphatic spaces, lots of mitoses. So it throws some stains on here to figure out exactly what it is. And the book chapter, of course, goes into more detail. That's actually all the unknowns for that chapter. But, in terms of what thyroid looks like and what all those other things look like. And knowing the stains, I think, would be useful, because that's probably more what you get tested on. I think you'd probably see in the derm path, you might see some metastatic breast, and you got to pick up on that with the Indian filing and stuff. But it's probably more going to be a stains question in like a multiple choice question. So now the next, or the last section, which there's actually 15 slides. I'll just kind of go through them quickly. But it's more the exogenous stuff, which most of it is in Appendix 2. Although there's some random things in here too, like this first slide, which is fixed drug eruption, which we've technically done already. It's sort of in the interface chapter. And so, from scan, you can see that there is, something going on in the epidermis, although it certainly looks acute because there's just a normal basket weave on top. And it's a little busy, a little something kind of in this papillary dermis, but not really anything going on deep. So we get a little closer in, and you can start to see there's certainly an inflammatory infiltrate, and definitely that basket weave horn, so something more acute. But there is an interface dermatitis and spongiosis as well. So it's kind of a mixed, spongiotic / interface dermatitis. And the interface isn't blatantly obvious per se unless you get a little closer, but you can see there's some vascularization, and there's a lot of lymphocytes, and there's hopefully you'd see that there's tons of spongiosis. There's a reason for all these lymphocytes up in the epidermis. It's just normal exocytosis. It's not epidermotropism like MF. And then there's sort of this chronic appearance to the papillary dermis. So there's some fibrosis and homogenization of this area just underneath the DEJ. So this sort of papillary fibrosis. There's some what looks to be some almost LCV-like change to some of these superficial vessels. There are some neutrophils in here and even some charectic debris. you wouldn't be wrong to think of something in the neutrophilic realm like sweets, but this certainly isn't as pronounced as it should be for sweets. And remember that certain drugs can give you a more of a neutrophilic infiltrate. But then that chronic appearance, which includes lots of hemosiderin deposition, and textbook, ideally you see this hemosiderin even deeper, so kind of down in deeper vessels, which hints at the chronicity. But when you pair these things together, acute basket-weave horn, the interface, spongiotic, kind of chronic appearance though to the papillary dermis. There's eosinophils in here too. It definitely makes you think of drug, and then hopefully the history kind of helps you, or the picture of it being fixed drug. And I didn't mention, but there's all these apoptotic keratinocytes in here too, so that kind of helps to point towards drug. But it certainly isn't full thickness necrosis, although you can get to that stage if you're getting more like a bolus fixed drug and it's more pronounced. But it's not looking like EM or TN. That's that one. So sort of exogenous, I suppose. And then this one is a suture granuloma. And you can see up top here, this is probably a scar. There's maybe an excision here of some sort. And then deep down here, you might be, from scan thinking, is this some, infectious thing? Is this some foreign body? Is this, something else going on? But it's really just a granuloma, a lot of histiocytes. And the slide is kind of faded, and I'm not going to actually polarize, but there's maybe some lighting up with diffraction. And especially with this little one over here, you can kind of see that it looks almost like there's actual stuff in there that's sort of polarizing. So this is suture granuloma. Sometimes the suture can be very well pronounced and have that bluish color to it and everything. So yeah, suture granuloma. Not that exciting. Okay. Well, this one is acute radiation dermatitis. So again, technically exogenous. And unlike chronic radiation dermatitis, where you can look for a lot of the features and all the things, which there's a slide in here of that, acute radiation dermatitis really just looks kind of like an acute, typically horrendous phototoxic eruption. And so it's kind of like a really, really bad sunburn type reaction. And so you're seeing this sort of vascularization and death of the epidermis, but there's not really a whole lot of infiltrate. It's kind of variable in its appearance. This one was maybe acute to subacute because it is kind of a thickened horn in a sense. But you're not going to see, because it's not chronic radiation dermatitis, you're not going to see the ectatic vessels or the stellate fibroblasts or that morphiiform change to the dermis. It's really just this sort of acute death of the epidermis. It's kind of like that sunburn. You're going to see certainly some apoptotic keratinocytes, but you're seeing more confluent death really than that. But there are some apoptotic keratinocytes too. And then just sort of this mixed, subtle infiltrate here and some vacuolization. But this is acute radiation dermatitis. Okay, this one is Gelfoam, and is a good one to know because stuff like this you absolutely can see. Maybe it'll be a picture slide on the boards, or it could be a real slide. But that's why we go through some of these exogenous things, because they're very much testable. But usually, if you just spend a little bit of time to memorize them, they have very characteristic appearances. This one has what's called the arabesque pattern, which goes with Gelfoam. And for a while, I didn't really know what arabesque meant per se, so I Googled it. And so if anyone hasn't Googled that yet, basically it's kind of like the old school Moorish architecture and Middle Eastern design, and you'd recognize it if you saw it because you see it on rugs and things. But that's what that means. And so this is an arabesque pattern, and it has also that kind of sort of sclerotic appearance. So, it's pretty characteristic. And hopefully there'd be a history of surgery and stuff, or some sort of procedure. Let's see, this one was Morbilliform drug eruption. And I guess this one's good because it highlights how it can be frustrating both for the derms and the dermpaths with this sort of reaction pattern, because it's just sort of it's often nondescript. And here, it's maybe some subacute subtle spongiosis. There's sort of this mixed, or actually I'd say predominantly lymphocytic, maybe lymphohistiocytic infiltrate that's perivascular, a little bit in the papillary dermis. There's some Langerhans cell granulomas, speaking to more of this sort of eruptive, slightly eczematous eruption. So it's pretty nonspecific. There's certainly eosinophils in here. We always like to say that helps you think of drug, but of course you can see that in a lot of different things. So on this one, you'd probably get a differential, and it would come back saying, well, it could be eczematous, it could be drug, it could be a lot of different things. So it's we see this a lot because it's pretty common, and we wish we could be more helpful sometimes. But a little bit of extravasation of red blood cells, that probably gives some clinical change too. But otherwise, pretty non-specific findings. Okay, I'll try to go through these a little faster. I'm run out of time. So this one is Moncell's. Now, it's interesting that over here, so it almost looks like there may still be something in here, or that could just be granulomatous reaction. From scan, this looks like it's a blue nevus, right? And that's kind of how Moncell's is. That's what you want to learn about it, because it's certainly not a blue nevus. Over here, there is enough cells that are in here. They're probably, though, just all histiocytes. But I looked at this before, and if you get kind of closer in, these guys, some of them almost look like melanocytes. So they don't really look like classic blue nevus cells, though. So these are probably still just all histiocytes, and it's more of a granulomatous response. But there's even some fine stuff in here that almost looks like melanin. But it's not melanin, and certainly the majority of this is absolutely not melanin, because it's these larger yellow-brown globules that are somewhat refractile. See here, you put the condenser down, and melanin is not that way. So really this whole thing, even though it kind of looks like a blue nevus and whatnot, it's just Moncell's tattooing. And so especially over here at the base of the scar, wherever this prior biopsy was, these more globular, refractile, yellow-brown things, that's just Moncell's, and kind of looks almost like hemosiderin, and it would be very much positive for Pearl's iron stain and some other things. So it's not melanin, but you can see why that would be a little confusing. So this one is an amalgam tattoo. This is salivary gland, which is always good to know, because even though we don't really deal with salivary glands that much, it's a good indicator of location. So then you go over here and you see that this is mucosal skin. Maybe it's a lip or something, or just a mucosal biopsy. But this black area here is the amalgam tattoo, and can be from mercury and silver and other things. Just that amalgam that's there that can produce clinically what appears to be sometimes like melanoma, and so that's why we biopsy it. And but this is sort of what it looks like, just sort of these fine little particles, a little bit more diffuse and like fine wispy appearance than a true tattoo that's more kind of man-made injected. But so that's sort of what this looks like, amalgam tattoo. So this one is meant to show the aluminum chloride reaction, and I was looking through this earlier. I don't want to spend a whole lot of time on this because this is something you guys have probably seen before. But there's a few things that can happen from that aluminum chloride that we use very commonly after biopsies. And you can see, from scan, it looked like a little scar, probably a little shave biopsy. And then if you get in closely, you can see that there's some stuff that you might confuse with weirdness. Meaning, like some of this purplish change here, this is what's called aluminization of collagen fibers, where it's actually like aluminum that's either precipitating or depositing or whatever on collagen. And then the main reason why this is in here is to show you all these histiocytes that are full of aluminum. And unfortunately, this is not the best example. So even though they're here, the best example would be one that looks like leishmaniasis, because that's sort of what it's called a lot of times in the derm path world, is it's like pseudo-leishmaniasis. Because sometimes those aluminum chloride granules can be so kind of focal and finite and visible that they look like little tiny intrahistiocytic organisms, and so it looks almost like leash. So you can kind of make that out here, but they're more just kind of this amorphous appearance here. But you don't want to confuse that with leishmaniasis. It's just aluminum chloride pseudo-leash. That's pretty much it for that. So this one is just tattoo with pseudoepitheliomatous hyperplasia. And, I just flipped it the other way. So there we go. And, this one would be, you'd want some history. You'd want to make sure that there's not actual something in here, like blasto or something else that could create that pH. There's not really pus, though, or neutrophilic abscesses, but there is this, pigment here, and so maybe they're getting a, horrendous response to the tattoo pigment. It's not really granulomatous or sarcoidal, but this is just tattoo pigment, and it's hard to say exactly why they're getting that pseudoepitheliomatous hyperplasia response, but that's what this is. Tattoo. Okay, this is number 10. So this one, I believe, was Argyria. Let me just double check. Yeah, so this one's Argyria. So this is on your normal skin differential because, as you can see from scan, everything looks normal. And so if you got something on a test where, that's maybe the one that's like meant to be really normal skin and kind of hard and you have to hunt for a while, hopefully from scan you're kind of realizing that there doesn't seem to be much going on. The epidermis looks normal, both the horn and the rest of the epidermis. There's maybe a hint of infiltrate around different places. But if you quickly try to go through that mnemonic, which I think is like I vacuum dog pus or something, there's different ones, but that's one of them. You'd come across Argyria, and so you'd want to look down at the eccrine glands, because you also want to see are they necrotic, is it a coma blister or neutrophilic eccrine hidradenitis or something. And here, it's kind of cool actually, but you can kind of see all the stippling is the silveros. This is the Argyria. And so as you get closer in, you can make that out even a little bit better. So that's what you're looking for on that normal skin differential, which obviously is pretty small and hard to find, and so you have to be looking for it. Okay. And then speaking of neutrophilic eccrine hidradenitis, that's also in here, commonly from different things, but particularly like cetirabine and stuff. And all you really see here, there is sort of a mixed, a subtle dermal infiltrate, but mostly what you see here, it's not the best slide ever because it's a little overstained, but there are a lot of neutrophils in here. So that's that neutrophilic eccrine hidradenitis. It's not really causing necrosis in most cases, or particularly earlier on, but there are lots of neutrophils in here. And remember, the neutrophils can be pretty pink, to where they almost look like eosinophils, but they're going to be trilobed, kind of like that segmented antibodies and stuff. So these are all neutrophils. Okay, so this is the chronic radiation dermatitis, and this one has pretty much all the classic features. A little bit of hyperkeratosis in the horn. You get certainly effacement and atrophy of the epidermis. There's some vacuolization that's still there, usually that can make it look even more like connective tissue disease or dermatomyositis or more morphiiform. And then certainly the dermis supports that sort of morphiiform appearance, sort of homogenization of that dermis, a lack of adnexae, these wildly ectatic vessels, the stellate fibroblasts. So I mean, all those features are things to look for. You can see here pretty well those stellate fibroblasts, and then that sort of vacuolization of the DJ. But I mean, it wouldn't be wrong to think of connective tissue disease, and you'd want to get some history. And the stellate fibroblasts certainly point towards radiation and the lack of adnexae. You can still see the pallor erector muscles, though. Okay, so 13. This one is a silica granuloma, and it's not the best ever cut of it. It's just sort of this area here off to the side. But you remember there's a lot of different things that can give you different granulomatous responses, sarcoidal granulomas and other things. So this is kind of in the sarcoidal granuloma differential, as well as like borreliosis and some other things. And this one, I think somewhere in here, oh yeah, over here, that you could see actually some of these refractile little guys here. There, you can see these little refractile silica within some of these spaces, and creating this granulomatous response. So don't just jump to sarcoid. Of course, it could also be a patient with sarcoidosis who happens to have a silica granuloma. Okay, flip this one around. So this one is minocycline hyperpigmentation, and it's just important to remember the different types of minocycline hyperpigmentation, and that you can certainly get deposition. This one, you could easily confuse with dermal melanocytosis, and because it even has what appears to be almost dendritic melanocytes, but it's really just a dendritic form of these fibroblasts and macrophages that are picking them up. And what would help you here is identifying the fact that these are large yellowish globules. So again, this is not that fine non-refractile melanin. These ones are a little bit more refractile and larger globules. And sometimes that condenser can help to identify that. But so this usually would be even more that bluish gray clinical appearance, but is another reason for pigment in the dermis. And the last one, this is basically radiesse, calcium hydroxyapatite, and certainly you can see that there's something going on here in the dermis, and it's all these little round, kind of calcified looking things that are very much refractile. Especially as you get closer in here without the condenser. So that is radius. This is kind of more this very well, small, homogenized things that are then in this sclerotic dermis. So that's radius. Permanent fillers. And that's it. Kind of more of a unique grab bag.